Welcome to the lecture on drug-drug interactions between cannabis-based medicines and other medications that patients or cannabis users might be taking at the same time. So why do I need to know this? As increasing numbers of people use cannabis-based medicines, we really need to be very aware of potential drug-drug interactions with other medications. And it is becoming quite clear that there are a lot of medicines that cannabis does interact with, and that can either increase or decrease the effectiveness of those medicines. And so we need to be aware for patients that are taking multiple medications where potential drug-drug interactions can occur. Sometimes this can cause side effects. And sometimes the side effects that are ascribed to cannabis-based medicines actually come because of the interactions that cannabis-based products are having with the other medications that a patient is taking. And a classic example of this is in epilepsy, where cannabidiol interacts with one of the anti-epileptic medications that patients are taking, and the side effects that are seen in the epileptic patients are because of that interaction with the anti-epileptic medication, which is now circulating at higher levels, and its metabolite is circulating at higher levels, and that causes many of the side effects that are seen when cannabidiol is added into an epileptic patient's treatment. So the side effect isn't necessarily coming from the cannabis-based product itself, but from an interaction it might have with other medications. And cannabidiol, we're learning, does interact with many medications, and this is something that's really becoming, it's quite a novel area of research, and we're only learning about it because of all the trials that have been done in epilepsy, and because cannabidiol does happen to interact with anti-epileptic medications. It became clear that there were drug-drug interactions there, and so people have started looking for drug-drug interactions in other spaces as well. And probably the most important thing is that drug-drug interactions can be very dangerous. They can be very dangerous to a patient because of the fact that you are either increasing or decreasing the efficacy of one of the medications you are taking. And so that can mean you have a worsening of symptoms because the medication isn't working as well as it should do. Or you can have side effects, as we've just mentioned, where one of the medications is working more than it should do, but that also causes more side effects than would normally occur. And in worst case scenarios, drug-drug interactions can be fatal. So when we are adding medicines together in a pharmacology setting, or when a pharmacist is adding a new medication into a second medication, we always need to be aware of where the potential interactions lie. And so with most prescribed medications, when a doctor goes to prescribe that medication, there will be warnings on them about what drug-drug interactions you need to watch out for. So, for example, it might suggest don't give this medication to a patient who's also on X, Y, or Z. And that's because we've learned a lot about them through the clinical trial research and data that's been collected in patients using those medications over years. But in cannabis-based medicines, we just don't have that repository of data. So we don't, because these aren't always licensed products that patients are using, we don't always have enough information about what the drug-drug interactions might be. This is something that we're learning a lot more about. And so hopefully in the future, we might be able to give some warnings about which phytocannabinoids in particular interact with which medications. So here is a lot of references if you want to go and look any further into this research area. There's a whole load of references here, and I will have gotten a lot of the data in this lecture from these references. So what we're going to try and cover today is firstly just a little bit of pharmacology and what are drug-drug interactions and how do they happen, because if you understand that, then you'll be able to apply some rationalization in your own thinking and try and figure out for yourself maybe where there might be a potential drug-drug interaction. Because if you know how one drug works and you know how a cannabinoid works, then you can predict what drug-drug interactions might occur. But also this will just help you to understand what's going on in the body when you are taking multiple medications at the same time. I'll talk about some of the known drug-drug interactions with cannabidiol first, because we know quite a lot about cannabidiol. It's a medicine that is being trialed quite a lot, so it's in a lot of active clinical trials at the moment, and because of the known interactions with anti-epileptic medications, people are being a lot more cognizant of potential drug-drug interactions with cannabidiol. But there is also literature about drug-drug interactions with THC, although we probably know a lot less about THC, or with other cannabis products, whole plant products, or enriched extracts. So a lot of what the information that we have with these products is really based more on case reports at this point. And I'll talk a little bit about why we might see more drug-drug interactions with cannabidiol than with other products. So let's just go back a step and talk a bit more about drug-drug interactions, which are often just referred to as DDIs. So the definition of a DDI is a change in the action or side effects of a drug caused by concomitant, which basically means taking two things at the same time, concomitant administration with a food, beverage, supplement, or another drug. So there are multiple interactions that can happen, and it's not just with medicines. It can be things like grapefruit, or supplements like St. John's worts, or beverages like coffee. So we know a lot about how food and drinks and supplements and other drugs interact with drugs, and most of this is because of interactions of all of these compounds when they're being metabolized by the liver. So a drug-drug interaction, as I mentioned, can increase the actions of a drug. So it can make a drug act more potently, or cause higher levels of a drug, and so that might make it work better, and so that can have a positive effect. Or there can be interactions with drug at a kind of mechanism of action level where they work better, and sometimes that's known as synergy. Or it can decrease the action of drugs, and this often happens. Actually, I would say it's more likely that you see a decrease in the action of a drug because it's being metabolized more than it normally would be. And this can lead to adverse effects, as I mentioned, and this can be because you have too much of a drug circulating, or you have too much of the metabolites of a drug circulating, and sometimes it's those metabolites that can cause side effects. Or it can just be that because your medicine isn't working anymore, the adverse effect is that you're having a re-emergence of the symptoms because they're no longer being treated by the medication that you're using. So how do drug-drug interactions happen? So there's really two main mechanisms by which they happen. The first is at a pharmacodynamic level. So this means where there is an interaction between, and I'm going to say two drugs because really that's what we're talking about in this lecture. I'm not going to talk about the food and drinks, but where there is an interaction between two medicines, two drugs, where they act at a similar mechanism of action. And so this means that they either act at the same receptor or maybe the same enzyme. And this can lead to either an increase or a decrease in drug effectiveness. So say if one drug inhibits a target that the other drug acts at, then that's obviously going to decrease drug effectiveness. Or sometimes two drugs can act at similar targets, or targets that are nearby each other, and they can cause synergy. They can increase the actions of both drugs. And we described this already in the pain lecture, where we talked about how CB1 agonists like THC actually act in a synergistic way with opioids, because the opioid receptor and the CB1 receptor are found close to each other on the cell membrane. And when they're activated at the same time, you get a better analgesic response than if you activate either one separately. And so that's an example of a drug-drug interaction, but where you're seeing a positive effect, where you have a synergistic effect between two drugs, which leads to both of them working better. Now that's good because it means that you can lower the dose of either drug, but you have to know that that interaction is going on in order to be able to lower that dose, because otherwise you might have plasma levels of both drugs that are unnecessarily high. So pharmacodynamic interactions is where basically two drugs, two medicines are competing at the same site, and it can either block each other's ability to work, or it can enhance each other's ability to work. Now, you can also have pharmacokinetic actions, and this is where one drug impacts the course of another drug through the body. So when you take a drug, it has to be absorbed into your system, it has to be transported all around your body, it gets metabolized, and then it gets secreted. Those four elements of a drug's fate are what we call pharmacokinetics: absorption, transportation, metabolism, and excretion. And one drug can influence the course, any one of those four elements of pharmacokinetics of another drug. So one drug can affect the absorption of another drug, or the transport, or the metabolism, or the excretion. But what happens most often is that one drug affects the metabolism of another, and that's really where most drug-drug interactions occur. It's because at the liver, which is where we break down our drugs, one drug can influence how another drug is broken down. So this is the most so in drug-drug interactions in general, so not just talking about cannabis-based medicines, but in all drug-drug interactions, it's more likely that you're having a pharmacokinetic interaction where one drug is influencing the metabolism of another drug. And so an example of this in cannabis-based medicine would be cannabidiol and clobazam, which is an anti-epileptic medication. Now, when you take the two of these at the same time, CBD inhibits the metabolism of clobazam, and we'll talk a little bit more about what that means. And this for cannabinoids or for cannabis-based medicines, interactions at the metabolism is also the most common way that we see DDIs with cannabis-based medicines. So I wanted to take a moment here to come back to the entourage hypothesis, because this is something that's talked about a lot. And for me as a pharmacologist, the entourage hypothesis is really just a drug-drug interaction. We're really just talking about the fact that multiple chemicals in the same cannabis-based product can lead to a drug-drug interaction. And in the case of the entourage hypothesis, what we're assuming, or what we think is happening, is that we're having an enhanced effect of having multiple chemicals present in a compound. And so from what I've just told you, you can say that must be at a pharmacodynamic level, where these compounds are maybe acting at the same target sites and enhancing each other's ability to act at receptors, or it can happen through a pharmacokinetic interaction where they are modulating each other's metabolism. And so the entourage hypothesis is an assumption that there are drug-drug interactions between phytochemicals, and that can be phytocannabinoids or terpenes or flavonoids, so it could be any of the constituents of a plant or an enriched extract that lead to improved efficacy. So for me, I just call this a drug-drug interaction. Entourage is a word that has developed around this kind of specifically for cannabis-based products. So where is the evidence? To be honest, in terms of pharmacodynamic interactions, we don't have good scientific evidence that there is pharmacodynamic interactions between cannabinoids, with a few exceptions. So one exception would be that we know that CBD dampens the CB1 effects of THC, and so that you have less of a psychotropic effect of THC when CBD is present. So you might consider that a positive drug-drug interaction, because CBD is able to dampen down that psychotropic effect, and some patients don't want those kind of side effects from a cannabis-based medicine. Now, if you want that euphoria, if that's something that you're looking for in your product, then clearly that's not a good thing. You don't want to have too much CBD there, because that might reduce the euphoric effects of THC for you. So that's an example where we do know that there is some interactions at a pharmacodynamic level, but we don't have very good evidence, for example, that phytochemicals at CB1 receptor have any kind of synergy or additive effect. What's more probable to me, and this is just based on my reading of the literature, is that there's pharmacokinetic interactions between the phytochemicals that are present in a mixed product, whereby there is either competition for their metabolism, or they are influencing each other's metabolism. And so that means that you have increased plasma levels of some of the phytochemicals that might be the more pharmacologically active ones in an enriched product, which is most likely to be THC and CBD. So if having all these other chemicals chemicals around slows down the metabolism, for example, of THC or CBD, then you can see you would have increased plasma levels of the compounds, and that would be a good thing because it would mean that they would be able to act for longer. So for me at the moment, the best evidence with the entourage hypothesis is that multiple phytochemicals in a mixture influence each other's metabolism. That has a positive effect to increase plasma levels of these compounds, and there may be some pharmacodynamic interactions whereby you have additive effects at multiple receptors, but this just hasn't been fully elucidated yet. So I thought that was a good point to try and explain further what the entourage hypothesis is. So we'll go back to the metabolism interactions, because as I said, this is the most common way that drug-drug interactions happen, and understanding this really helps us to figure out what's going on in the body. So most drugs are metabolized in the liver, and that means when a drug is metabolized, it usually terminates its action, because usually when it's broken down into something else, some other kind of molecule, then it stops doing the job that it was designed to do. So metabolism of a drug in the liver really determines a lot of the drug profile. It determines how long it stays in the body. So some drugs are broken down quite slowly and they stay in the body for a long time. Other drugs are broken down quite quickly in the liver, and so they have quite a short duration of action. So the way the drugs are broken down in the liver is by a family of enzymes, liver enzymes, called cytochrome P450 enzymes, and this is often abbreviated to just CYPs, CYPS. And CYPs are this huge family of liver enzymes that break down most medicines and other compounds in our body. That's the job of the liver. So they come through, they're absorbed in the intestine, they're brought to the liver, they're broken down. Now, as I said, the rate of that breakdown of a drug will determine the profile of a drug and how often you have to take it, how long lasting it is in the body, how much of it you need to take, because if you have a drug that's metabolized very fast, then you need to take quite a lot of it. So there's lots of the features of a drug is very much determined by its metabolism. There are hundreds of different types of these CYPs, and they all have letters and numbers after them. So you have CYP3A4 or CYP1AC, and this is just like a nomenclature way of giving them names based on what they do. And there are hundreds of them in the liver, all with quite specific functions and specific types of molecules that they break down. And medicines are normally broken down by a specific CYP isoform, and an isoform is just another word for saying a type. So each one of these specific types of CYP enzyme will normally break down a particular medicine. Sometimes a medicine might be broken down by 2 CYPs, but it's usually just 1 CYP. And so knowing which CYP your medicine is broken down by really helps you to predict whether or not you might have drug-drug interactions with other medicines, because some medicines inhibit some CYPs and some medicines induce some CYPs. And inducing a CYP means that you make it act even faster than it would do. So if an enzyme is working more than it normally would do, then it chews up the medicine that it normally metabolizes much quicker. So it's like putting it into overdrive. So these are enzymes, and they're monooxygenases, which means they oxidize compounds, lots of different types of things, steroids, fatty acids, xenobiotics, and the medicines that we take. So there are some CYPs that we know are particularly involved in drug metabolism. So the most common CYP for drug metabolism is CYP3A4. So this metabolizes about 1/3 of all medicines. And then you've got CYP2D6, 2C9, 2C19, and 1A2. So these are the CYP isoforms, or the particular specific types of CYPs that we know break down most of the medicines that we take. And we know that there are many naturally occurring compounds that can either induce or inhibit these CYP enzymes. So we know, for example, that St. John's wort induces CYP3A4, so it makes that enzyme work harder. Now, if you're taking another medicine that is broken down by CYP3A4 and then you start taking St. John's wort, the problem is you're making that other medicine be metabolized faster, and so it's not going to be working as well when you start taking the St. John's wort, and so that can lead to problems. We also know that tobacco smoking induces CYP1A2, and watercress inhibits CYP2E1. So there's a lot of kind of common foods and things that we do that we know affect CYPs, and so these kind of warnings will be on medications that are metabolized by these particular CYPs. It'll say don't take with St. John's wort, or smoking can do this or that. So we know the product information of a medicine normally details all of these kinds of things. And I've already mentioned the fact that the majority of drug interactions is because of interactions of metabolism, and that's also true for any kind of cannabinoid or cannabis-based medicine drug interactions, because we know that cannabinoids inhibit most of these major CYPs that break down medicines, and so that is of course going to mean that there's going to be interactions between cannabinoids and a lot of the major medicines that we use. So the final slide, really just talking about how this happens, is to go into a little bit more of the nitty-gritty of what happens when you take two medicines at the same time. So let's say, for example, that you're taking drug A and it is metabolized by a specific CYP enzyme. We'll say 3A4 because it's the most common CYP enzyme. And then you start taking drug B, and drug B inhibits that particular CYP. And we know about that. And so what that means is that if drug B is inhibiting the CYP that normally breaks down drug A levels are going to remain higher in your body, in your plasma, for longer, because its inactivation has been slowed down. If you're going to inhibit that CYP, and that's the only way that this drug is normally broken down, the drug is going to be around for longer. It's going to have higher plasma levels for longer in your body. Now that can be good, that can increase the efficacy of drug A, especially if you maybe weren't taking enough of that drug, but it can also be bad, because there is always a therapeutic window with a medicine where you've got a sweet spot where it works, but then levels higher than that can have toxic effects and can induce side effects. So that can lead to quite a wide range of adverse reactions or side effects to drug A, because drug B is causing drug A to be around at higher levels than you would expect in the body, or might be good in the body. So let's look at the flip of that. So what if you're taking drug A and it's metabolized by a particular CYP, say 3A4, and drug B increases the enzyme activity of that particular CYP, so it makes that CYP work harder. And so what that means is that CYP is then chewing up drug A at a much faster rate than it normally would. So that has the opposite effect, in that the blood plasma levels of the drug A will fall quickly. And so what can happen there is you just don't have enough of that drug in your body to be doing what it was supposed to be doing. So you can have your symptoms coming back if you're, I don't know, whatever you're taking drug A for, that's basically no longer being therapeutic in your body. So it can cause a decrease in the effectiveness of drug A. It can also have another impact whereby if the metabolite of drug A is toxic in the body, so say drug A is normally broken down to a metabolite, and now that's happening at a much faster rate because drug B is increasing the activity of the enzyme that breaks it down, it can mean that you have quite high levels of the metabolite hanging around in your blood, and that can lead to side effects as well. And then there is another interaction that can happen where you're taking two drugs at the same time, which is just competitive inhibition. And this is where two drugs are being broken down by the same enzyme, but there's a limited capacity of these enzymes in your liver. And so if you're taking two compounds at the same time that are normally being broken down by one enzyme, that enzyme just gets a bit overloaded, and so there's too much substrate there for it. There's too much of drug A and drug B, and so it just the metabolism of both of those drugs can slow down. And so what that means is you get higher levels, plasma levels of both drug A and drug B for longer than you would expect. And that, like scenario A, that can increase the efficacy of both drugs. If you're still within that therapeutic window, having a bit more of each of them could be a good thing, unless it's going too high and you're getting toxic levels of either of the drugs, or too high that you're getting increased side effects of either of the drugs. So that's drug-drug interactions and how they happen, and the fact that most of them happen in the liver because one drug is influencing either in a positive way or negative way the CYPs that break down another drug. So let's talk about how this happens with cannabis-based medicines in more detail. So I've briefly mentioned already the fact that cannabinoids are known to inhibit CYPs. And this is a table taken from the review quoted here at the bottom, where it looks at some of the common phytocannabinoids, THC, CBD, and CBN, and their impact on a whole range of different CYP enzymes. And you can see that they inhibit a lot of these enzymes with varying degrees of potency. So if the number is less than about 1 micromolar, it's not very strong at inhibiting that enzyme. But you can see, for example, 2C9, all of the phytocannabinoids inhibit 2C9 at concentrations less than 1 micromolar. So that might turn into something clinically significant. If you look at 3A4, THC isn't very good at inhibiting 3A4, but CBD is. So CBD can inhibit 3A4 at 1 micromolar. So anywhere where the number is less than 1, you're going to think that this might lead to something significant in a person. Now remember, this data is generally generated in vitro, which means that you look at this in a laboratory setting. So it doesn't always translate into drug-drug interactions in a whole human taking two medicines at the same time. But what you can see is, and this is just some of the phytochemicals, is that most of them have some interactions with CYP enzymes to varying degrees. And so there are multiple possibilities for DDIs that you would predict based on this kind of data. So what about clinical observations? What have people actually seen and what has been published in the literature on clinical observation of DDIs with cannabinoids? So we're going to start with the drug interactions between cannabidiol and anti-epileptic medications, because this is where it's really come to light that cannabis-based products, particularly CBD, can cause DDIs. And I've already mentioned the fact that there is an interaction with the anti-epileptic medication clobazam, which a lot of patients will be on when they add in CBD into their medication. So this has been known for several years now, and there are several reports, there are several publications that you can look at that has detailed this, but this is one of the first publications that showed an interaction between these two medicines. And what happens is that when the plasma concentrations of clobazam and its metabolite were found to increase in children taking CBD, because CBD inhibits clobazam metabolism. And preclinical work that has looked into this in further has found that CBD blocks CYP3A4, which we already showed in the previous table. It's pretty good at blocking that isoform. And this isoform normally breaks down clobazam. So that explains why when you take the two medications together, you get increased plasma levels of clobazam, because it's not being metabolized by CYP3A4 as it should be, because CBD is inhibiting that. But it was also found that CBD also inhibits another CYP, which is 2C19, and that isoform normally breaks down the metabolite of clobazam, which is called N-clob. And so that actually has an impact as well, because not only is CBD breaking down the metabolism of the main drug, the parent drug, it's also inhibiting the metabolism of one of the metabolites of clobazam. And that is leading to some of the adverse effects of this drug, this combination of drugs. There may also be some pharmacodynamic interactions at the GABA-A receptor, where there may be enhanced inhibition with the when the two drugs are given in combination. But the majority of evidence suggests that it's because of inhibition of metabolism. Some people postulated that this is why CBD works. It's not actually that CBD itself is anti-epileptic. It's just enhancing the ability of this anti-epileptic medication to work because it inhibits its breakdown. But that has been refuted now, and I think I mentioned this already when we in the epilepsy lecture, that people did a meta-analysis of all of the clinical data of epileptic patients who'd taken CBD either in combination with clobazam or not with clobazam. CBD still works. So it might contribute to some of the effectiveness of CBD, but it's not everything. It's not the only reason that CBD works in epilepsy. It definitely contributes to some of the side effects that are attributed to CBD. And again, this meta-analysis here showed that if you take out the trials that have been done in epileptic patients, you see far fewer side effects of CBD. And so a lot of the side effects that are coming in these patients are actually because of clobazam and its metabolite. That's what's causing those side effects. So what about other anti-epileptics? So stiripentol, there is probably some small inhibition of the metabolism of this anti-epileptic drug, and for some patients dose adjustments may need to be made, so you may need to lower the amount of this anti-epileptic medication that is being taken. So a lot of patients will see this as a positive thing, that they're able to lower the doses of the concomitant anti-epileptic medications that they're taking, because CBD it allows for that, because you still get the same plasma levels because CBD is inhibiting the breakdown of these drugs. So you can do a dose reduction with these medications. And then sodium valproate, there's probably no interaction at the level of metabolism. So CBD doesn't affect the metabolism of sodium valproate, but there is an interaction here between these two compounds, because both have been shown to have some liver toxicity. So both of these medications can cause some liver damage. And so when you are taking multiple medications that have the same side effects, you have to be careful that you are not then causing excessive liver damage in a particular patient. So caution really needs to be taken with patients taking both of these medications, and monitoring of liver enzymes should take place in order to make sure that they're not getting too high if patients are taking both medications, both of which are causing some level of liver damage. So it's not necessarily a drug-drug interaction there, but it is an interaction that we need to be conscious of. Now, the other area in which we have some evidence which is based in larger patient numbers is around cannabis and cancer therapies. And this is something I alluded to in the cancer lecture, is that we really still don't know enough about how cannabis might impact a cancer patient. And we need to be a little bit cautious about cannabis use, and we need to learn a lot more about the interactions it might have with other chemotherapy or treatment strategies that patients are on. And there is at least one medication where there is possibly a negative interaction between cannabis-based products and the cancer therapies that the patients might be on. And this is particularly with an immunosuppressant therapy called nivolumab. And the first study showed that patients who were using patients with advanced cancer who were using cannabis had a reduced tumor response to this medication. So basically, they were less responsive to the medication. And this is a medication, it's an immunotherapy drug that's used to treat quite a wide range of different cancers, from skin cancer, neck cancer, lung cancer, renal cancer. So lots of different, it's quite a widely used medication. So they found that across all patients that the response rate to this medication was lower in those patients who were taking cannabis compared to those who weren't taking cannabis. And this was observational data. They didn't find there was any particular association of the percentage of THC or CBD to response rate, so they couldn't identify which compound might be having a drug interaction. Just cannabis per se was associated with a reduced response rate. So, and the overall survival rates of the patient wasn't affected. So even though the drug was less responsive and the tumor was less responsive to the drug in these patients, their overall survival rates weren't affected. So it wasn't quite clear what was going on with this observational study. There is now a follow-up study to this, which was recently published, and this is looking at 102 patients, again on the same immunotherapy with advanced cancer taking cannabis or not taking cannabis. And what they found actually in this study was that using cannabis was not associated with good clinical outcomes. So cannabis consumption correlated with a decreased time to tumor progression and overall survival. So in this study, they did actually find that cannabis use had a negative impact on overall survival. But they did find that the cannabis users had a lower rate of treatment-related side effects, and also side effects associated or immune-related side effects. So they did better. Their side effect profile was better when they were using cannabis, but their overall time to survival and tumor progression was worse. So it's not clear at what level this interaction might be occurring. So we don't know yet whether this is a drug-drug interaction or what's happening, but it seems to be specifically related to patients who are particularly taking this type of medication. So I think further research needs to be done on this. And again, caution should be taken with patients who are using cannabis to manage their cancer symptoms. Make sure to tell your healthcare provider what you're doing, and if you're taking a medication like this, you need to be cautious of the potential interactions and implications. So now we're going to look at some case reports, because this is really where most of our clinical data comes so far and gives us a bit of a hint about where drug-drug interactions might be occurring to look in the future. So warfarin is a medicine, it's a blood thinning drug, and it's a medicine for which we have a number of case reports of interaction with cannabis-based products of various types. So people will take warfarin if they've had a stroke or a heart attack. It's common to be then given warfarin or some kind of blood thinning agent to try and reduce clot formation in the future. So let's first talk about CBD. So there are a couple of case reports. This isn't the only one, but it's the one that I've highlighted for today. There are case reports of people having a drug interaction between CBD and warfarin. So this one is of a 44-year-old male with post-stroke epilepsy. So he's had a stroke, which is a blood clot in his brain. So these kind of patients would typically be given warfarin after their stroke to try and stop blood clots being forming in the future. And his stroke has caused epilepsy, and so at some point he has introduced CBD into his medication to try and manage the seizures. And what happened is when this patient started taking CBD, he found that the effectiveness of his warfarin really increased. So warfarin is monitored using this thing called the International Normalized Ratio, which is basically a measure of blood clotting. And so the higher this number is, the longer it's taking for your blood to clot. And it's how clinicians will monitor whether warfarin is working or whether you need to increase the dose of it. And when this patient started taking CBD, this INR number started increasing quite significantly. You can see it's the green line on the graph there. It started increasing very significantly, showing that it was taking longer and longer and longer for this patient's blood to clot. Now, this can be quite dangerous, because if your blood doesn't clot, then you are at risk of bleeding out. So if you were to have an internal bleed, you could potentially, if there was a cut internally, you could be bleeding internally and not know. Or if there was an external cut and your body, the blood won't clot, then that could be really dangerous. And so the response to this was to decrease the dose of warfarin to get the INR number back in the range that you want it to be in. And what the researchers postulated is that this was possibly due to inhibition by CBD of CYP3A4 or potentially 2C9. Both isoforms are known to metabolize warfarin. So it's the same isoform that metabolizes the anti-epileptic drug clobazam. So you can see this is a pattern emerging, that drugs that are normally metabolized by 3A4 might be particularly affected by CBD. It's not just CBD, so there are also lots of case reports of people taking cannabis and warfarin, and this is a patient who is treated with warfarin because they had a mechanical heart valve replacement, and so they're taking warfarin to try and keep their blood thin and stop clots from happening. And this was just recreational use of cannabis, so it wasn't for a medicinal reason, but they presented to the hospital with a very elevated INR. So again, it was taking this person's blood a very long time to clot. And these inhibitors suggest that it was more likely that the interaction was because THC inhibits the 2C9 mediated metabolism of warfarin. And there are many other case reports reporting similar DDIs with warfarin. And it has also been shown that THC, pure THC, can have an interaction with warfarin. So this is another case report of an older man who had chronic pain and was also taking warfarin and presented with increased INR levels. So again, it was taking a long time for his blood to clot when he started changing the dose of his THC. So multiple cannabis-based products seem to have an interaction with warfarin, leading to the warfarin being more effective, but that can be dangerous because of the inability of blood to clot. And so caution should be taken. The INR should be monitored, and if necessary, the dose of warfarin decreased as long as a cannabis-based product is being taken at the same time. So this is a case report with CBD and tacrolimus. Now, tacrolimus is an immunosuppressive drug. It's a calcineurin inhibitor, and it's used in various types of situations where you want to reduce inflammation. And so this is a patient who had interstitial nephritis, which is inflammation of the kidney, and they were also participating in a CBD trial for epilepsy, so they also had epilepsy. And now you can see they're taking quite high doses of CBD, which is typical of patients, epileptic patients. And because they were being monitored through the clinical trial, and that's really an important point that I'm going to come back to, is that the reason we know a lot about drug-drug interactions with cannabidiol is that these patients are being quite closely monitored when they're on drug trials, and so any kind of side effects will be investigated. But if you are somebody who's not part of a clinical trial, you may not realise that drug-drug interactions are occurring. So when this patient started in the CBD trial, it led to a threefold increase of their tacrolimus concentrations. So you can see, again, it's because of drug-drug interaction where the metabolism of tacrolimus was being inhibited. And so the tacrolimus dose needed to be reduced as a consequence, because the levels were getting too high and were causing side effects in the patient. And this is suggested to be due to inhibition by CBD of CYP3A4, which is the main CYP enzyme that metabolizes tacrolimus. So again, medications that are metabolized by this pathway are consistently being shown to be inhibited by CBD. So there is also evidence that tacrolimus, so the same medication, can be that there can be drug-drug interactions with cannabis-based products. So this is an older gentleman with lymphoma who started on a tacrolimus drip, but was also taking edible marijuana gummies for management of his cancer. And when he was using these, or when he was eating these THC-containing gummies, his blood tacrolimus levels were spiking and continued to rise over time. The patient was in hospital and was showing signs of tacrolimus toxicity. So as I mentioned, when plasma levels of some drugs get very high, it can have a very dangerous effect on the body. So it was causing diarrhea, body stiffness, tremors, and altered mental status in this patient. And so the dose of tacrolimus needed to be reduced, and they were advised to stop taking the gummies. And the suggestion by the authors is that this was because of inhibition of CYP3A4 by the gummies, but obviously without knowing exactly what was in them, it's hard to know where the drug-drug interaction was occurring. And this is a recent case report that's come out about a potential interaction between cannabidiol and lithium. So as more people start taking cannabidiol for different neurological disorders, I think we're going to begin to see interactions with other medications other than just those that are in the epilepsy sphere. So this is an autistic patient, a young 13-year-old who had epilepsy and autistic with lots of other psychiatric problems, and was being treated with multiple medications, both anti-seizure medications and psychiatric medications. And so that's the potential for lots of drug-drug interactions to occur. When his dose was increased to 10 mg per kg per day, he started developing a lot of symptoms and side effects that were typical of lithium toxicity. So hypersomnolence, meaning being very, very sleepy, ataxia, not being able to move, decreased oral intake. These are typical signs of lithium toxicity. And so this was queried whether or not this is what was happening. He was also taking other anti-epileptic medications, including clobazam, and it was found that a drug-drug interaction was occurring with the clobazam, and so that was decreased to 50% of its initial dose. And when he was admitted to hospital, he was found to have very elevated lithium levels. So again, it was suggested that the metabolism of lithium was being inhibited by the presence of CBD. And so in this instance, the lithium was discontinued. He stopped taking the lithium and his symptoms resolved, which indicated that it was lithium toxicity that was occurring, probably due to an interaction with cannabidiol. Okay, so it's not all bad. So sometimes drug-drug interactions can occur that are good. And I just wanted to remind you that we did talk about this already in the pain lecture, that there are positive drug-drug interactions between THC and opioids, which mean that they work better together, and so the dose of either can be reduced. And so this is because the CB1 receptor and the opioid receptors are co-localized at the cell membrane. And when the two of them are administered at the same time, you need a much lower dose of opioid to cause the same analgesic effect, which is obviously a very positive thing. And some observational studies seem to support this. So observational data coming out is suggesting that patients who are using cannabis-based products for pain can reduce the prescription of their opioid medications. So about a 50% reduction in opioids in the patients that have been monitored in these studies. I guess it's also a benefit to other patients because the interaction between CBD and other medications usually means that the other medications need to be dose titrated down, so they're taking a reduction in the dose of those other medications, could also really be seen as a positive thing. I guess the reason I'm more cautious about it is that you've got to know, you've got to be aware of where these interactions are happening. And at the moment, the case reports are quite serious that are coming out. And so, but if we knew in the future, it was very well established that you don't need as much warfarin if you're taking cannabis, or you don't need as much lithium if you're taking cannabidiol, and then obviously that would have a similar impact in that we could reduce the dose of some of these other traditional medications when people are taking cannabis-based medicines. We just need to learn more about how these interactions occur and what we need to do as a consequence. So something that I thought I should mention is why more drug-drug interactions seem to occur with cannabidiol than THC. And I think there were probably several reasons for this, and it's difficult to know what the main driver is. It's probably a contribution of all of these points. But firstly, I wanted to say that we're picking up a lot of drug-drug interactions with cannabidiol because there are a lot of clinical trials going in this area, and the patients are being very well monitored. And because we know about the drug-drug interactions with anti-epileptic drugs, we are really looking out for drug-drug interactions with cannabidiol and other medications that we know are being metabolized by the pathways such as 3A4, where we know that CBD seems to be having an inhibitory effect. So because the research with CBD is really active and ongoing at the moment, it's just an area where we're picking up a lot of drug-drug interactions. And so it could just be that we're looking for them more, and that's why we see it more with CBD. Another potential reason is that the doses that are used, the doses of CBD are far higher therapeutically normally than would be used for THC. And so that means there can be greater plasma levels of CBD, and that might be driving these drug-drug interactions because we have more of the drug around, so that increases the likelihood that the CYPs will be inhibited because there's more CBD around. So it could be a dose-related thing, and therefore you would infer, or you would hypothesize that with high enough doses of THC you would actually start seeing drug-drug interactions because there would be more of the drug around to inhibit the CYPs. And another reason is that some of the data, the in vitro data that I presented in that table a few slides back, suggests that CBD does inhibit some of the CYP enzymes more than THC. So it's a more potent inhibitor of CYPs, and it seems to inhibit more CYPs than THC does. So for example, THC didn't look like a great inhibitor of 3A4 in that table, whereas CBD was. So maybe we're going to see more inhibition of 3A4 metabolism by CBD than by THC. So I think it's a combination of the fact that there's we're looking out for these DDIs more with CBD. Potentially we've got higher plasma levels of CBD, especially in areas like epilepsy, because of the very high doses that people take of CBD. So you've got more CBD around, and because CBD seems to be better at inhibiting some of the CYPs than THC. But I think that these are just theories, and so but I think that if there were quite a significant drug-drug interactions with THC, we would have seen more of this in the literature. There would be a lot more case reports of DDIs with cannabis products if there really was strong DDIs with THC. So the fact that there aren't, because people have been taking cannabis for a very long time, is very widespread whilst taking lots of other medications. So that the fact that there aren't that many case reports of DDIs with cannabis-based products makes me think that it's probably the fact that CBD is better at inhibiting these CYPs and the doses are higher. So for me, that stands out as the strongest reason at the moment why we see more DDIs with CBD. So I was asked to mention what drugs do not interact with cannabinoids? And I actually found this really quite a difficult question to answer, because without having specifically looked at a potential drug-drug interaction with a potential medication, it's very difficult to say that they don't happen. And when I say specifically researched, I mean a full pharmacokinetic, pharmacodynamic range of studies. And that really just hasn't been done with a lot of cannabis-based products and different medications, with the exception for CBD and the anti-epileptics. So it's really difficult to say what doesn't interact with cannabinoids, because this kind of thorough research really hasn't been done, and because drug-drug interactions often go unnoticed, so they will not get reported unless they end up in quite a serious situation. So most of the case reports that I talked about is where a patient has ended up being hospitalized because of a potential drug-drug interaction, or because of the severity of the side effects from their drug-drug interaction. Small drug-drug interactions probably just go unnoticed in a patient. So if there are only small changes in the metabolism, you would only know about that if you actually did plasma analysis of the levels of each of the medicine that person was taking. And small changes in the efficacy of a medicine, so a small increase or a small decrease, probably won't get noticed by a patient. And you might attribute a change, feeling a bit better, to your new drug, whereas actually maybe it's just that the new drug is making the old drug work better. So we don't always notice small changes in drug efficacy, and you might not report that to your healthcare professional, and so it may not ever get recorded as a DDI. So what I'm saying is that DDIs normally only get picked up when there's a real significant problem, or, for example, at the moment through in clinical trials where people are being more cognizant of DDIs. So it's really difficult to say what drugs don't interact with cannabinoids because of that reason. But you should definitely, if you yourself are using a cannabis-based product, or if you're advising somebody who's using a cannabis-based product, you should definitely talk to your healthcare provider whenever you feel that there's a change in your medicine, either that it's not working or it's working more, and especially if you've started a new medicine or a new dose of a medicine. And if you feel any new or unusual side effects when starting a new medicine or a new dose of a medicine when you're taking other medicines, again, you should report that, because those side effects could be typical of the previous medicine. Let's say drug A, you start taking drug B and suddenly you start reporting side effects that are typical of drug A. Now, you might think that those side effects are because of drug B, but actually if you talk to your healthcare provider, like for example with the lithium poisoning, you might realize actually no, there's something going on here, and the side effects that you're reporting are because of your other medication. So unless you're talking really well with your healthcare provider about these kind of things and aware of the fact that drug-drug interactions can occur, then these things aren't being recorded. And so we do try to need to record them better, drug-drug interactions better, especially as more and more people use cannabis-based products for medicinal and recreational reasons. So let's conclude this lecture then. Cannabis-based products can have significant drug-drug interactions that require monitoring and dose modification. And our best information about this, or our best clinical data so far, really relates to cannabidiol and specific interactions with anti-epileptic medications, and also case reports of drug-drug interactions with other medications that are known to be inhibited, or that are known to be metabolized by the 3A4 pathway. And this includes warfarin, immunosuppressive drugs like calcineurin inhibitors, and lithium. There are also case reports of drug-drug interactions with cannabis and warfarin and immunotherapy agents that are used in cancer. And there are also case reports of drug-drug interactions of THC with calcineurin inhibitors and warfarin. So these are medications that you definitely need to be aware of a potential interaction if you're using a cannabis-based product. although it's possible that other medications that are metabolized by the same pathways will similarly be affected, and I think we need to be more cognizant of that and try and record that data better. So drug-drug interactions are often only picked up through clinical trials or with extreme interactions where it leads to hospitalization or a patient going to their healthcare provider because of severe side effects. So because of this, DDIs might be more prevalent than we realize. And if we start being more aware of this, we might be able to record this better for other patients so that it doesn't end up being so serious that somebody ends up in hospital. And thankfully, the drug interactions usually mean that the dose of your other medication can be reduced. And so for a lot of patients, that's a really positive thing when they're on multiple medications of high doses. There is some evidence of pharmacodynamic interactions happening between cannabis-based products and medicines, and the best example of this is the positive interaction, pharmacodynamic interaction between THC and opioids that mean that the analgesic effects of opioids can be achieved at lower doses when THC is present. And I'm assuming that there will be other pharmacodynamic interactions out there that we just haven't learned about yet, but it is possible to have positive DDIs between THC or other cannabis-based products and traditional medicines. And if the entourage hypothesis is true, then it is probably a combination of pharmacodynamic interactions between phytochemicals and also pharmacokinetic interactions between phytochemicals, where they synergize and work additively together and potentially increase the plasma levels of each other. So finally, I just want to say that this is really an area that we need to learn more about. We need to record better and eventually just apply appropriate warnings on medications or on supplements or recreational products, that you need to be careful when you're using some of these products, probably particularly CBD. And the use of CBD is becoming very prevalent, although it's possible that the over-the-counter type doses may not be sufficient to have some of these drug-drug interactions. We do need to be aware of them and start making consumers and patients aware of the fact that if you're consuming products like CBD, that there could be interactions with your other medications that you need to be mindful of. Thank you.